Hello friends, I am Dr. Sourabh Patwardhan from Nandadeep Eye Hospital, PG Teaching Institute and FECO SICS Training Center, Sangli, Maharashtra, India. In our center, we have a lot of teaching activities which includes hands-on training as well. This particular video must be watched by everyone in the ophthalmic OR, and you will see why it is important. Gone in 100 milliseconds. It's a must watch video. Let's see what are the interesting things happening in this particular case. End of the case, very nicely done case by the surgeon, and surgeon is going to implant a toric IL. It's a hydroimplantation procedure which the surgeon prefers. IL goes in the antechamber, and there suddenly the IOL is now just hanging by the iris. Let's watch it in slow motion again. So the hydroimplantation being done, there is no visco in the anterior chamber except the one coating the IOL. The IOL goes in nicely, no problem there with the IOL insertion, and then suddenly you find this happening, and you find that the PC is ruptured and the IOL is barely hanging on the iris there, one haptic just hanging by the iris. So did the surgeon have enough time to react in this particular case? So when I slowed down 100 times, you can see the millisecond timer there. In just 100 millisecond, the instrument, that's the irrigation probe, had already hit the posterior capsule, and you could see that the IL had already gone down within just 100 milliseconds, and our usual reaction time is 150 to 200 milliseconds. So there is no possibility that the surgeon could have avoided this. And why did this happen? So the assistant was giving the second probe, that's the aspiration probe, to the surgeon in his right hand, and by mistake the assistant hit the surgeon's left hand which was holding the irrigation probe. That was a mistake, and that sudden push gave rise to this incident where it went right through the posterior capsule, hit the IOL, hit the posterior capsule, torn the posterior capsule there, and that's why now the IOL was hanging upside down there. Of course, the surgeon was shaken by this incident and was just confused what to do now. The IOL was there, right there, hanging. So the surgeon immediately called another surgeon to just have a look. So the second surgeon washes in and using a forceps catches that tip of the haptic and could pull out the haptic through the incision there. And now using the left hand visco cannula under the IOL pushes the IOL further up, making sure that the vitreous doesn't prolapse along with it. And now the both the haptics are brought in the anterior chamber. Anterior chamber is now filled with very good dispersive OVD there in order to protect the endothelium when the second surgeon is going to explant this IOL. The CCC size appears to be large, so the chances of optic capture are ruled out. The surgeon increases the incision from 2.8 to around 3.5 there, and surgeon is going to use the twist technique. So right hand, the McPherson, a long one, is holding the IOL at its edge. The left hand, a thin iris repository, is protecting the endothelium, as the right hand is twisting the IOL clockwise in such a way that it folds inside and then comes out. The twist technique of IL removal here is used just for to show it again so that you can practice it and you can do it. Just make sure that when you hold the McPherson, it is sideways you are holding, so that you have good option to rotate the wrist now clockwise. Here in this case, I am rotating it clockwise because you can see the haptic configuration, it is reverse, that is, it is like S shape. So that's why I have to rotate it clockwise. If it was opposite, you can also do it anti-clockwise and remove it. It's a very good technique to know. You don't need any scissor or aisle cutting instruments for this. Once the eye is out, the surgeon is making sure that there is no vitreous. So vitrectomy has to be done because you could see the dial was hanging upside down in the vitreous. So the vitreous is cleared. So I think this is a very important video to be watched by all the ophthalmic technicians as well, OT assistants and nurses, because you have to be mindful when you are assisting, and any such inadvertent push to the surgeon's hands, even surgeon's chair, or to patient bed, patient table, patient's head, can lead to sudden jerky movements in the surgical field and can lead to such complications. So, everyone who is attending ophthalmic OR, even those who are observing surgeries, have to be always mindful to be very careful in the, particularly when they are in contact with the anything which is connected with the patient. So that's what is being done now, that the 3-piece aisle is placed first in the anterior chamber, then it was dialed nicely into the sulcus there, and then finally the visco is being removed, and at the end the surgeon will do the optic capture. So it is very well managed case. The patient did quite well. Unfortunately, this patient could not be implanted with the toric aisle, but fortunately the toricity was not much, so patient still had fairly good unaided vision. And luckily the steep axis is where the incision is taken, and we have already enlarged the incision, so that kind of negated a bit of astigmatism. The surgeon made sure that the wounds are sealed at the end because we have done vitrectomy. The eye will be hypotonous. So the suture is taken, which is removed at the end of 1 week. It's better to suture rather than not suture in these cases where you have a higher chances of wound leakage in the post-operative period. So that's the end of the case. So just again, I'm showing the movement. So this is what happened. Handing over the second probe to the surgeon's right hand, the left hand of the surgeon was pushed by mistake. So just be mindful and watch this video again. Thank you so much.